Have it.
Stallion has to be positive for
That's
ARQ.
exposed to that stallion's blood, either by previous pregnancy or transfusion, not his particular blood for that particular factor, blood transfusion, or some kind of placental dysfunction. In order for her to be exposed to that particular factor, so she creates alloantibodies against it, the foal has to inherit those blood group factors of the stallion. And last but not least, the foal has to ingest and absorb colostrum. Right. Went through the clinical signs. Diagnostically, PCB is going to tell you the level of hemolysis. It's going to give you an indication of when you need to replenish red blood cells, as well as a prognostic indicator on this animal survival. Remember, the source that we mostly want to use is going to be the mare, washed red blood cells from the mare. And then while we're using this, we have to remember we have to support this baby through this stressful event. So there may be the possibility of needing prophylactic antibiotics. We have to consider possibly some kind of gastric protectant, okay, protect against ulcers, those type of things. All right. In terms of prevention, you can blood type your horses so that you'll know. Most likely not going to happen. You can check the mare within about 3 weeks of parturition. You can check her with a Coombs test to see if she has those circulating antibodies already. If it comes down to the baby is born, last but not least, jaundice foal agglutination test, a combination of colostrum and the red blood cells of the baby. Look for hemolysis or agglutination. That will let you know about how this baby nurse this colostrum, all right, for about 30 hours. Do not separate the baby, muzzle the baby. Milk the mare, all right? If you don't milk the mare, they don't have that hormonal influence to continue to have milk let down, all right? So milk the mare every couple hours. 30 hours out, you can put them, you pull the muzzle off and allow that baby to nurse. Now, it's described more in equines than anything else, but you can have it happen in food animals. All right, ruminants and swine can get it. The way that they become sensitized, or the way that they get exposed to that other blood group factor, is usually by way of using some vaccine of blood origin. So in pigs, things like hog cholera vaccine. In cattle, things like anaplasmosis vaccine. Okay, so if they don't have it, they get vaccinated, get exposed to that factor, create alloantibodies. Progression goes from there. Okay. All right, moving on. Severe combined immunodeficiency. All right, equine AIDS, no T or B cell function. All right, remember, babies can produce they can produce their antibodies, but they can't produce things fast enough to rise to a challenge. So usually for the first 2 months of life, they're surviving off what immunoglobulins they get from the dam. Excuse me? Yeah.
Yeah, I think you thought you were asking which antibodies. When you said
Oh, no,
what
no, no, no.
antibodies.
Okay, got it. I'm sorry. I wasn't, but that's okay. Okay. Anyway. All right. So, first 2 months, they have to survive on what they get from the dam. With this disease, they usually don't start to show clinical signs until about 2 months out. Can they show it earlier? Yes, it depends upon the level of passive transfer. No, the level of transfer of passive immunity. Okay? So, if they got good, y'all already know, I've already said this many times, so I'm gonna go back to the other one they said. If they had good passive transfer, all right, then it'd be 2 months out before they start to show something. If they had some level of failure of passive transfer, then they show clinical signs earlier, right? No T or B cell function, they can't function on their own. This is what they need to do to protect them from disease. So 2 months out, they start getting sick from different infectious diseases. Septic arthritis, diarrhea, pneumonia. They just follow the cycle. They get over one, they'll develop the next one. Because they won't have any inherent mechanisms to protect them from disease. Okay? Happens in Arabians and Arabian crosses. It is autosomal recessive. So, if you get this disease, that means both the stallion and the mare are heterozygotes. They're both carriers. It's lethal, they will die. So there is no treatment for it. All right. Antemortem, the test is an intradermal phytohemagglutinin test. That is the only antemortem test for this disease. All right, on necropsy, what you're gonna find now, there will be a little bit of IG, they may have a small amount of IgM, but for the most part, they're also absent in terms of IgM. Okay. Now, on necropsy, thymic hypoplasia, in other words, thymic tissue is replaced by fat, adipose tissue. Persistent lymphopenia. Those are the type of things you notice. Now, what can you do? You can blood type your horses, so you know who's the carrier, and realize that if you breed those carriers, you got a 1 in 4 chance of having a baby that has immunodeficiency. But it's strictly Arabians and Arabian crosses. Okay? What's next? Tummy fold. Neonatal maladjustment syndrome, hypoxic ischemic encephalopathy, dummy fold, dummy calf, wanderers, barkers, all that are all names for neonatal maladjustment. Same syndrome. CNS disorder, afebrile non-infectious CNS disorder. All right. Associated with a hypoxic event. Leading to CNS disorder, cerebral edema and hemorrhage, which gives you CNS disorders. They are displayed by behaviors such as wandering around, abnormal vocalizations, possible seizures, loss of suckle reflex, right? Things like that. Afebrile, non-infectious. Now, you have two categories. You have that which occurs at birth, that which occurs 24 hours later. So you got like a category 1 and a category 2. All right. Pretty easy to diagnose because, like I said, afebrile, non-infectious. All right, these are foals, calves wandering away from their mothers. Like I said, abnormal vocalizations, poor supple reflex, sets them up for failure to pass the transfer. Now, those that don't show the signs until 24 hours out, category 2, may very well have gone through the whole thing of having good pass and transfer, or they may not, but they may have if they're not showing signs until 24 hours out. Those that show it from birth, obviously, are going to have a problem. So once you recognize the disease, then the idea is, what do you do to treat it? All right? Treat the severe CNS signs first. If this animal is showing seizures, seems like I was about to have. Seizures, yeah. All right, if the animal is showing that, all right, then treat that. All right, keep that animal from mutilating itself, traumatizing itself, that type of thing. All right. After that, we need to address the cerebral edema and possible hemorrhage. We need to put that in check. How are we going to do that? DMSO, IV, Mannitol, IV. All right, take care of that cerebral edema. As in any intense medical case involving a foal, we got to think about prophylaxis, all right, in terms of other diseases due to the stress, in terms of GI protection, all right, cut down on the possibility of GI ulcers. And without a doubt, we have to check and make sure that this baby's got the right amount of IgG. So we have to make sure we test. Okay, usually treatment, they usually treat these babies like 3 A's in a row in terms of DMSO or mannitol, whichever. If you have seizures, then we have to we're treating with Valium, or we're controlling them with Valium. All right, now, small animal or large animal. Why not use ace-promazine to kind of sedate this animal because it has seizures? Huh? Somebody say it louder. Pretend like it's, I just walked in the room and y'all are still loud. Okay, so what's the answer? All right, it lowers the seizure threshold. I know somebody else probably said, but you didn't speak up. Okay, so it lowers the seizure threshold, so we don't want to deal with ace-promazine.
I know recently they proved that doesn't happen in small animals, but that's the same in large.
It does happen in large. I couldn't tell you with any amount of confidence it does small. If I told you that was small, I'd be telling you a story. I don't know. All right? So remember, you got to cover all the bases. First, we want to make sure the animal doesn't traumatize itself. Then we want to make sure we handle cerebral edema, prophylaxis against disease, make sure IgG levels are where they're supposed to be, protecting the gut. All right, all the above. Okay. Prolonged dystocias, usually is probably the most common thing, but any kind of hypoxic event can be premature separation of placenta. We have fescue toxicity. Fescue toxicity not only causes agalactia, but it causes mares to have extremely thick, heavy type placentas, and these babies can't break out of them. Hence a hypoxic event. Okay, moving on from there. Lever white syndrome. recessive, autosomal recessive. Yeah, autosomal recessive occurs in paint horses, overo to overo crosses. Causes a mesenteric aganglionosis. These babies show signs that are consistent with colic. All right, so gut pain, grinding of teeth, being casted in the stall. All right, things like that are going to be indicative of this disease. They have that lack of pigmentation in the skin, hence lethal white. But they have, like I said, they have this aganglionosis. Differentials can be meconium infection, Atresia ani, or Atresia coli. All right, so all about doing a good physical. All right, it is lethal. They're not going to make it. Does not matter what their past transfer is or anything like that, they're not going to make it. Okay, let's see what's next. Metabolic stuff. All right, ketosis. I did. Showing epileptic signs, anti-freaky coloration. Also recessive, hypothyroidism. Yeah, all of that. Yes. Only disease that is probably confused with is there is an idiopathic epilepsy that you can get in Arabians, but they go out of it at like 12 to 18 months. And that's probably the thing that's kind of closest to it. That discoloration, well, not discoloration, but the freaky hair coat color is usually consistent in all the cases. Every now and then you don't have it, but it is recessive. Something that I pulled out of there somewhere. I saw a question about it somewhere. That's the only reason why you brought it up. Never seen it, except on the slides. But usually they don't make it. Okay, going on to ketosis. All right, ketosis, purely an energy deficiency caused by more going out than what's coming in. Energy that's going out is usually associated with production either of milk or of baby, or both. Okay, you have type 1, type 2, type 3. All right? Type 1 is the type of ketosis that we see in heavily producing, lactating dairy animals. Divided into two clinical pictures, or two clinical forms. One is digestive or wasting, the other one is nervous. All All right, digestible wasting, loss of condition, weight and condition, depression, anorexia, sequential inappetence. In other words, they stop eating grain first, stop eating hay next, grass last of all. Decrease in production of milk, acetone breath, may show some neurologic signs, like some ataxia, depression. We don't expect fever. All right, now, so those are two clinical syndromes. Ketosis can be primary, or before we treat it, ketosis can be primary or secondary. In other words, primary ketosis means it is the entity that is causing the energy deficiency. Secondary means some other disease is causing anorexia, so not enough food is coming in, or not enough energy is coming in. All right, so you can have secondary ketosis from any disease that causes that animal not to take in enough energy. So secondary ketosis can be associated with arthritis, toxic mastitis, anything that keeps that animal from eating. Okay, so back to that primary. Okay, treatment.